Hello, and welcome to the Dr. Rebecca Baxt podcast. I'm Dr. Rebecca Baxt, board-certified dermatologist, and I'm here to discuss with you all issues relating to the skin that you're in. In this podcast, we will tackle the topic of the day quickly to get you the take-home points that you need. After listening to an episode, you should be educated about the topic and able to fix the issue yourself or well prepared to ask the right questions at your next dermatology appointment. Let's get started. Today I'm going to discuss actinic keratosis. Actinic means sun-related, and keratosis is a fancy term for a growth on the surface of the skin. So actinic keratoses, in plural, happen in sun-damaged areas, often the face, the head, ears, arms, backs of the hands, legs, sometimes on the back, often on the neck. Really, anywhere that the sun hits, you can have an actinic keratosis. They're often red or pink and rough and scaly. And I explain to patients when there's a spot that you keep moisturizing and it won't go away, actinic keratosis comes to mind as a possible diagnosis. They're often easier to feel than to see because they can also be flesh-colored. And the trouble with actinic keratoses is not that they are themselves actually particularly dangerous. They are considered precancerous and not life-threatening in any way. The problem is if they stay there and continue to grow, over many years, a small proportion of them will become squamous cell carcinoma of the skin, which is then an actual skin cancer. Now, this process does take many years. And so actinic keratoses give us a long time to work on them and try to make them go away. And so now that we know what they are, where they occur, what they look like and feel like, I would like to discuss my approach to treating them. The first most important thing is sun protection. Actinic keratoses are from the sun, and stopping sun exposure is the best way to protect the skin in the future and prevent more from happening. So I recommend a sunblock SPF 30 or above every 1 to 2 hours, hats, clothing, etc. I have a whole episode of this podcast devoted to sunscreen and sun protection, so take a listen if you're interested in more details. But moving on to the ways that we can make the actinic keratoses go away. Number 2, starting from least aggressive to most aggressive, the least aggressive but very effective is Retin A cream, otherwise known as generic tretinoin. This is a prescription, and I will often have people use it in the evening, starting twice a week, Mondays and Thursdays, and increasing to more frequently as tolerated to the areas that are affected. This cream thins the top layer of the skin, and so it helps peel down the actinic keratoses and gets rid of some of them. Also helps prevent some from happening in the future. The downside of the cream is that it makes the skin more sensitive to sunlight, so patients always have to use sunblock and a hat, etc. And it also can create sensitivity to facial waxing because it thins the skin, so if that's an issue, it needs to be stopped before waxing at least 1 week before. If prescription tretinoin is too irritating or cannot be obtained, over-the-counter retinol is a lighter version and a good alternative. So after sunblock, hats, clothing, and tretinoin for treatment and prevention, the next most commonly used therapy is called cryotherapy. Cryotherapy is a very common treatment for lots of things in dermatology offices. The dermatologist usually has a little spray can of liquid nitrogen that we spray onto the spots, and the cold spray irritates them and makes them worse before they get better, but it's about 80 to 90% effective in removing the visible actinic keratoses in the hands of a good board-certified dermatologist. This is not for home use. There are home freeze-off things that you can purchase for warts in the drugstore, which I do not recommend. Cryotherapy is an in-office treatment. I tell patients not to do cryotherapy the week or so before a big event since the areas treated will be red and crusty, but usually within a week or two they are healed and smooth, but they can still be pink for a number of weeks, so to keep that in mind when they're planning their cryotherapy session. Cryotherapy hurts and stings a little bit, but it's quick and easy for both the patient and the doctor. So if cryotherapy is not a great option for whatever reason, or the patient has really so many actinic keratoses all over the place The next best thing is going to be Effudex or other topical chemotherapy. These creams will induce an immune response on the skin, making it very red and irritated, but thereby getting rid of the actinic keratoses. Effudex is generic topical 5-FU, or 5-fluorouracil, and it was discovered many years ago that when patients were getting 5-FU intravenously for chemotherapy, that the precancers and early skin cancers on their skin got very red and then disappeared. So it was then formulated as a topical therapy, and it's been around for decades. Effudex or 5-FU is typically used twice a day for 1 to 2 weeks in order to induce the immune response that makes the affected area red and irritated. The first time I have patients do this, I have them come into the office at the 2-week mark to see how much of a response they have had and discuss with them whether it's time to stop and let the area heal or if they need to do it a bit longer. One of the advantages to doing this treatment as opposed to cryotherapy is that it's what we would call a field treatment, and it treats the whole area, not just specific spots. And so the cream is smart and it sees things that we do not see and gets rid of most of the precancers in the area, even ones that are invisible to the human eye. I explain to patients that the cream is really a litmus test and a treatment at the same time. It detects the precancerous areas and also treats them. So if nothing turns red after 2 to 4 weeks, then there was nothing there and it was a bit of a waste. But typically, if we're telling people to use Effudex cream or another equivalent type of topical chemotherapy, then we are highly suspicious that it's going to get red and there will be something there. Patients have to be prepared to then let the areas heal, and this can be sped up by adding topical anti-inflammatory and topical antibiotic, such as bacitracin and hydrocortisone, but this is not mandatory. It will heal on its own, just with basic first aid and keeping it clean. Not everyone can tolerate this treatment, but it is very helpful. And there are other versions of it, such as Carac cream, which is a brand name of an Effudex that's lower in strength and takes longer to use, or Aldara cream, which is, again, a brand name of imiquimod, which comes in little packets and can be used typically every other day. Many doctors will add calcipotriene to their Effudex or 5-FU treatment, which is another prescription to try to make it heal faster. There are many different ways to do this type of field treatment. Effudex also comes in cream and liquid. It comes in different percentages. I tend to stick to the traditional, which is Effudex cream, 5% twice a day for 2 weeks. But there are other versions of similar treatments, and these all work well. Once I've done this with my patient and they've come in and they understand how to do it, I will often have them do the Effudex cream on their own in the winter, and they will either treat whole areas such as their arms or their chest or their legs or part of their face, or they can also use it as spot treatment. If they have a spot that's coming up that doesn't go away with moisturizer that they think is an actinic keratosis, they can spot treat and see if they can get rid of it. And I will do that with my patients who have a lot of these, who've done it, they understand it, and it can be a very useful home remedy. If they've used the Effudex on a spot and it doesn't go away, these patients know to come in and show me that spot. So the fifth option is photodynamic therapy, and not all dermatologists offer this treatment. I sometimes will get referrals from other local dermatologists to perform this on their patients because not everybody has the equipment for this. Photodynamic therapy, otherwise known as PDT, is FDA approved to treat precancerous actinic keratoses and also early basal cell carcinoma. We can treat any body part, but it's mainly used on the face or the top of the head. And this is how we do it. The patient arrives, we clean their face, typically with acetone to make sure there's nothing on their skin, and then we apply Levulan or Ameluz, which are 2 brand names of alpha-amino-levulanic acid, which then sits on the face for around an hour. Then we shine them in a blue light. They have goggles on to protect their eyes. This is not ultraviolet, it is just visible blue light. Some people will use red light. Either way it works. And as the patient is sitting there with the light on their face, with the chemical on their face, it causes a reaction. And the precancers and early skin cancers can get inflamed and then they go away. So the nice thing about this treatment is that it's similar to Effudex. It sees things that human beings do not see and treats the whole affected area. In addition, it doesn't hurt. The downside is it takes around 2 hours in our office, and it can make the skin very sensitive to light, both indoor and outdoor light, for up to 48 hours. So after the treatment, patients have to wear a hat and sunscreen and reapply their sunblock every 1 to 2 hours, even when they're inside, for 2 days afterwards. The other downside is, despite all these precautions, once in a while someone just gets very red from their PDT treatment. The redness goes away, but they can look like a cherry tomato or a lobster for a few days. I'd like to mention a sixth option, which is laser resurfacing or chemical peels. These are cosmetic treatments, but they do work well to reduce actinic keratoses. There's a whole podcast episode on Fraxel laser resurfacing, and that is another option if the patient does not want to do the medical options. Chemical peels are also an option. They basically are like giving the tretinoin or the retin-A a booster, and chemical peels help peel down the skin and rejuvenate it, and so that helps peel off the actinic keratoses. So in summary, actinic keratoses are precancers that can turn into squamous cell carcinoma skin cancer over many years. Not all of them will turn, just a small percentage, thought to be around 10% over time. But to reduce this risk, we like to treat actinic keratoses. However, because it takes so long for them to become skin cancer, and not all of them will become skin cancers, this is never an emergency and can be treated over time. I try to get my patients who have actinic keratoses to stop their sun exposure. I always say that they should be getting so little sunlight on their skin that they are actually vitamin D deficient and need to replenish their vitamin D with supplements, and to please have that checked at their next primary care visit. In any case, sunblock, hats, clothing to stay out of the sun, etc. are so important. Then secondly, I try to get them to use topical retinoids if they can tolerate them, a few evenings a week. Third, we figure out which treatment plan works best for them. It's often a combination of all the treatments, but I'd say cryotherapy is the most popular since it's the easiest. People tend not to like doing Effudex or other topical chemotherapy, but it is very useful and helpful in the treatment plan. PDT I usually save for people who have a lot of precancers, since it's a more involved treatment, but I would say that most patients who do the PDT are happy with it. I find that some of the cosmetic treatments that I do, such as laser resurfacing or chemical peels, are also helpful, but those are not usually the primary treatment. I hope this was helpful in understanding what is an actinic keratosis and what can we do about them. Thank you so much for joining me today on the Dr. Rebecca Baxt podcast. I'm Dr. Rebecca Baxt, board-certified dermatologist. I hope this episode was informative and that you enjoyed listening. If you found this podcast useful, please give us a 5-star rating wherever you get your podcasts. It helps others find us so we can help them too. Just a caveat to remember, this is not medical advice, and please see your dermatologist or doctor for questions pertaining to your specific situation. I look forward to talking with you again in the next episode.